This post looks at the coronavirus 2020 pandemic and inquires if clinicians above a certain age should only do telepractice during the pandemic. What we know is that outpatient medical care must go on during the pandemic. And I believe that it may make the most sense from a staffing perspective to create work environments that encourage clinicians above a certain age and those with comorbidities to focus as much as possible on telemedicine care. And this would reduce their chance of death significantly and ensure then that the most number of clinicians remain well and are able to provide care throughout the healthcare system as a whole. And so if we were to summarize this argument, there's three premises and a conclusion. Premise one is that the rate of mortality for the coronavirus starts to go up dramatically for the population of those above the age of 60. Premise two is that the rate of mortality for the coronavirus dramatically increases in those with comorbidities. And premise three is that as much outpatient healthcare as possible needs to be shifted and will be during the pandemic to teletherapy. And so based on these three premises, my conclusion is that the safest use of clinician resources is during the pandemic for clinicians above a certain age and with certain comorbidities to really focus on outpatient telemedicine care and younger physicians to focus on inpatient care. And if we were to look at these argument premises in a bit more detail, that premise one that mortality increases with age, the data from China looking at, for instance, 55,000 laboratory confirmed cases shows that the mortality rate of someone in their 20s is 0.2, in their 30s is 0.2, in their 40s is 0.4, in their 50s is 1.3%, in their 60s is 3.6%, and then in their 70s is 8.0%. And so what this means is that someone who is in their 60s has an 18 times higher rate of mortality than someone in their 30s, that someone in their 70s has a 40 times higher mortality than that of someone in their 30s. And so if you were to use these numbers, it means that if you had a clinical staff of 30 clinicians, if they were all above the age of 60, statistically one of them may die from coronavirus. And if you have a clinical staff of 30 and they were all below the age of 59, statistically no one should die in that group of 30. The data from Italy, some of the early data shows very similar types of trends. Someone who is 70 years old has someone who is in their 60s has a 25 times higher rate of dying from coronavirus as someone in their 30s to 50. And we now move on to that second premise that we have increasing comorbidities also increases your rate of fatality. And so looking at the Chinese case fatality rate data, if you have no comorbidities, your case fatality rate was 1.4%. And then when you add something such as diabetes, it goes up to 9.2%. Hypertension, it's 8.4%. Chronic respiratory disease, 8%. Cancer, 7.6%. Cardiovascular disease, 13%. And so again, we see increasing comorbidities, increasing rate of risk. And then that third argument is that we really need outpatient healthcare to continue during the pandemic. Why is this important? First, we know that hospitals and departments are aggressively looking to shift their outpatient services to be offered by remote care, FaceTime, telephone, email, Skype. And this is important because routine medical visits must continue. And if you consider, for instance, the many subspecialties in internal medicine where patients may be attending weekly, bi-weekly, monthly, quarterly appointments, critical adjustments are being made to their medications. For instance, immunotherapy and immunosuppressants are being shifted. Heart failure medications are being adjusted. New diagnoses and critical illnesses are being investigated. This cannot be put on hold for the pandemic, which is going to run an unknown duration. And the other problem is that if we reduce the outpatient service delivery, what will happen is that These patients who are sick chronically and have chronic conditions will end up becoming unstable, getting off the tracks, and then they end up in the emergency department requiring admission. And this is not only costly and dangerous to their health, but you can't have more chronic outpatients getting sicker at a higher than baseline rate during the pandemic, because this only exacerbates the situation in terms of healthcare emergency room utilization. And so that's why countries outside of Canada have definitely started shifting dramatically towards telemedicine services during this pandemic. And we must, of course, in Canada do the same. So when you look at all these three premises together, we get to this conclusion that it's probably safest if clinicians above a certain age and those with certain comorbidities focus as much as they can on remote telemedicine care. And so what this might look like in practice is, again, you have a rheumatology division, let's say with 30 clinicians. You might encourage those who are older to focus on outpatient therapy. You might encourage those who are younger to focus more on inpatient consults and therapy. Now, you might wonder, what exactly should the age rate cutoff be? If you look at the mortality data, you see obviously a large jump at the age of 60 and above, but some might argue that we should actually use a lower threshold for the age cutoff. We should recommend perhaps 50 or 55. And the thesis from this is, of course, completely speculative, but the idea is that potentially healthcare workers are exposed to higher dosages of the virus when they get it. And potentially that makes it more lethal than to the average community exposure. And so what this might mean is that the mortality data, if you looked at it specifically for healthcare workers, might show potentially a bump starting even at the age of 50 or 55 that you would want to mitigate. Now, this is all speculative. I haven't actually seen any data surrounding this, and if you, of course, have some, please send. But the idea would be that if you really wanted to be precautionary, you would recommend a lower age bracket, even then of 60, to really be encouraging those clinicians focus on telemedicine and remote care. Let's look briefly at some counter arguments to this whole idea. One would be that what if you have a healthy person who's above the age of 60? Well, I agree. We don't really know, to my understanding, what the data shows. The data from these countries is aggregate, showing that as you have increasing age, you have an increasing mortality, but we also know that comorbidities increase with age. And so I haven't seen data showing how a healthy 70-year-old compares to a 50-year-old with comorbidities. It is assumed that the 50-year-old with comorbidities has a higher chance or risk than the 70-year-old, but I don't really know what the exact data shows. So I think it would be safest just to use blanket age cutoffs rather than specifically the health of the individual. Because clinicians, especially physicians, are inclined to think they're usually much healthier than they might be are. The second counter argument is that you might not have enough staff to try to encourage these resource utilization changes. First, I think this is a faulty argument because I'm not suggesting that clinicians or physicians above a certain age stop practicing. I'm suggesting that their work is shifted to try to be done as much as possible through remote therapy. This could be done even from their own home. And so the hope would be that they wouldn't get sick, and therefore this would reduce their chance of death, and therefore they could keep caring for patients. So the intent is actually to have more clinical staff using this type of rearrangement. And also, if you pull the 2008 data, for instance, from the Canadian Medical Association, what you'll find is that the physicians who are in the age 65 and above group among specialist physicians comprise 16% of that group. So it's only 16% of all physicians are above the age of 65. Now, there is a column for unknown age, and if we assume, or let's just pretend that the unknown age are all above the age of 65 as well, when you combine those two columns, you get a total of 20% of specialist physicians being above 65 or older or of unknown age. If you lower it down, there's a cutoff bracket here from the age of 55 to 64, and if you combine that number of physicians in Canada who are specialists with the group of 65 and older physicians in Canada, you end up with 38% of the total number of specialist physicians in Canada who are above the age of 55 to 64 or 65 and above. So I do think this is possible on a system level to try these types of shifts. Certainly when you look at the numbers, the largest current cohort of specialist physicians and all physicians is coming from the group of people who are 35 to 44 and 45 to 54. That is 100% certain that that's the largest cohort, those two groups there of physicians in Canada. And fortunately, the overall data suggests that they also have the best chance of success and health in terms of total fatality rates when it comes to the coronavirus. And then the last counter-argument is that you really need the insight of a particular expert physician on an inpatient service. The thought would be that if that particular physician is of one of these age ranges we've been talking about, or that particular physician has multiple comorbidities and it would be at much higher risk for coronavirus, I would try to come up with creative methods using cell phones, video conferencing technology, remote chart access from home to be able to still have that physician be able to provide care, but potentially trying to mitigate them actually having to be doing as much of this in person as possible. Just because when you look at the total aggregate numbers, it is quite a high risk. For instance, if you had a 72-year-old practicing physician who definitely is an expert, let's say within your province or state, based on the absolute age data, they're at a significantly inclined risk of mortality than one of their colleagues who might be 20 years younger than them. Anyway, that's the idea. I don't know 100% what other people think of it. This idea really came from my brother, Robert. I think it's certainly worth considering when you're looking at healthcare systems and aggregate levels, especially places like the UK or Canada, where you have reasonably nationalized systems, and it's much easier to shift resources and look at these care populations from a system level at the whole, and not really just a single clinic.